So welcome back to Wednesday Echo. We are joined by Kate LePage today, who is the Regional Navigator for Safe Harbor through Lutheran Social Services, and she has been on our Echo a few times in the past. We love having her, as this is a topic that we all need to learn more about in order to better serve our addiction medicine patients.
And you are whom?
Who, me?
Yeah.
Who, me? I'm Erin. Everyone knows you're Kurt. We can probably move on with our lives.
I'm an IT specialist.
Right.
Yeah. All right. So upcoming sessions, some fun things coming up. Again, next week, our friend Charlie Resnikoff coming back to talk about hot topics. He's giving us a preview of this talk that he's going to be doing for the American College of Physicians. So we get to hear it first. And as usual, I'm sure it'll be great. And then Kate's coming back the week after. So lots of fun stuff coming up.
And then help us all, Kurt's doing the presentation here coming up in April. So hopefully there aren't any random bursts of music during his presentation.
All right, there's free CME. Remember, when she sends you that stuff, you got to send it back and then fill out the little thing that she sends you to get the CME. So make sure you do that. And remember, we love having people's cameras on because Kate wants to talk to people and not black boxes. So please feel free to turn it on.
And we want to see what you're having for lunch.
Yep.
If you have any technical assistance needs on any cases, anything like that, let us know. Our contact information is listed below.
All right. And remember, if you want to go on the website, you can find just about anything on the core website. Just refer to this slide. It'll just get you right where you need to be. There's all kinds of protocols, all kinds of stuff. So feel free to look into that. All right. And with no further ado, we will let Kate take over and she can share her screen and just maybe if you want to just kind of introduce yourself, kind of give people a pretty good idea what you do as well, Kate, that'd be great.
Yeah, I'll do that while I'm getting this pulled up here. And then I know that Erin said that I want to see your faces, but once I'm sharing my screen, I won't really see anybody's faces anyways. So if you turn your camera off, I won't even know. So I'm Kate LePage. I'm the East Central Safe Harbor Regional Navigator. I work out of Lutheran Social Service, but I'm funded through the Minnesota Department of Health. So I'm going to talk a little bit about the Minnesota approach to trafficking and exploitation. But I cover 11 counties myself. And then we just got a new grant out of my office for a new region in Northwest Minnesota. So I have 9 new counties to develop and be developing a new navigator up in that area. So I'm excited for additional challenges and new service areas and learning new resources. So hopefully, if I don't cover your area, I'll show you guys a map at some point if you would like to know who your local navigator is. I know people come from all over for these echoes. I'm happy to connect people individually as well. And I'll have my contact information at the end of the presentation, as well as on our first slide right here. I always try and be, fun with technology. And I guess I'm probably, I know you said I'm probably more tech savvy than you, and I don't know if I am. Every time I try and do something fun and interactive on a virtual training, it doesn't work. So we'll see how this goes. This is part 1 to a 2-part training. So I haven't been on in a while, since before COVID, and wanted to make sure everybody was on the same page with what trafficking is and what it looks like in Minnesota. And then in part 2, diving even further into the co-occurring traumas that we're seeing, specifically, our substance use and abuse correlating victimizations and concerns when it comes to trafficking. So I'll share a little bit of data about the connection between substance use and trafficking today, but go much more in depth into part 2. I do have limited time with you guys, and so I wanted to make part 2 as informative as possible as we kind of readjust ourselves with this foundation in part 1. And so I do have a QR code at the end that it's a 1 question Microsoft form, just asking what types of things you're hoping to hear more about in part 2, so I can embed that into that training as well. And again, make it as informative for you all as possible. So I'm going to minimize all the talking faces now and move into this. And if you guys are able to click or use the QR code if possible. If this doesn't work, we're going to move on real quick. I just thought it would be fun for me to get a better understanding of where we're all at on our training prior to jumping into the material. So if you are willing and able to scan the QR code, I hope it works. I'm not going to sit on this slide for very long, just another second or two, because I want to use our time to go through the presentation. But this, again, just helps me kind of get a pulse for where we're all at in today's training. So just a couple housekeeping items that I always do. One is a content warning. Especially virtually when I can't really read the room very well, I never know what people's personal experiences are, or sometimes as you're hearing things, it triggers memories from patients that you had. I'm never offended if people, I see how many participants are on, if that drops down, because you have to multitask or go do other things. I'm never offended. Self-care is the primary concern here, of course. So that's my content warning. Nothing is graphic or extremely graphic today, but again, just not knowing anyone's background, I always like to offer that up. I also just encourage people to check their preconceived ideas about what trafficking is. I've had so many requests for training in community, and so have my peers, especially, and I know COVID was a while ago, but I'll go back to that a little bit. During COVID, there's been a lot of myths that have come up around what trafficking and exploitation is. I actually have a podcast out with a couple of my peers debunking the myths and talking about how those myths really harm the movement, the anti-trafficking movement moving forward. So just kind of pay attention to those preconceived ideas that you have, and hopefully the information today kind of readjusts the narrative if there are some preconceived ideas. Then there's some language adjustments. So prostitution, it's still used in statutory language. It has really negative connotations that come along with it. So when we're talking amongst ourselves, our peers, our friends and family, in order to really present the correct narrative to our communities of what exploitation and trafficking is, shifting the language is going to really help with that. So victim, survivor, or someone that's been exploited. In the past, we've referred to buyers as Johns. When we do this, we really humanize the act by giving it a name. We minimize the act of purchasing. So trying in present to use buyer or an exploiter. Pimp as well. When we use pimp, we have these preconceived ideas that come to mind. And unfortunately, those same preconceived ideas are coming to the minds of the high-risk youth as well that are being targeted for grooming. And so instead of talking about this idea that's been portrayed in the media of what a pimp is, using trafficker and exploiter really better encompasses everybody that can be an abuser or a trafficker out there. And it helps especially young people or potential victim survivors better address concerns of healthy relationships rather than being more worried about, again, those preconceived ideas based on terminology. The other one that's still used in statutory language is child pornography. The term that is much more representative of what this entails is child sexual abuse material. So shifting that language as well. We're not going to talk a ton about child sexual abuse material, but I will say, as we move forward in time, that online exploitation or online solicitation of children is a really huge part of this conversation and can be used really to identify red flags of future contact victimization as well. And then just continued education. Obviously, I'm already coming back again in a couple of weeks, but continuing to educate yourselves. There are changes coming up with our mandated reporting statutes and guidelines as mandated reporters on this call. As those things change, just updating education and material that you have within your institutes is really helpful. I guess I will say too, I love dialogue and questions. I'll try my best to watch the chat if we have questions as we go, but I'll probably pause within every section to just see if there are any questions that we want to address right away. So in Minnesota, we actually take a public health approach to responding to human trafficking. There are other states that take this criminal justice framework. We're really blessed in Minnesota that we have a little bit of both that we operate off of. We have 4 funded task forces in the state of Minnesota through the Office of Justice programs. And then our state legislature, again, follows that public health approach. So our state funded resources, which we have kind of 3, and they're adding. We are always adding to them. It seems growing a little bit, but 3 main branches of funding for exploitation and trafficking victim survivors. And again, that all falls under that public health approach, which is really helpful for meeting people where they're at and following a trauma-informed response, which you guys all do in your practices as well in responding to the opioid crisis. So I'm really glad that we're all kind of operating under that public health approach, but it really allows us to advance individual health, to see people as patients and clients rather than just victims, and we can respond to people more holistically when we do that. It offers a much longer term process because we know that the journey past victimization is a bumpy road at times. So we want to make sure that we're not defining our services based on the one experience that's been identified within the criminal justice framework and rather able to expand on it. It really is community, family, and individual oriented. So we have a multifaceted approach to responding to the crisis. It's community-based and it prevents and treats harm. So we follow a harm reduction approach to responding to exploitation and trafficking. Again, we're really lucky here in Minnesota that we're able to also partner with this criminal justice framework and have a twofold approach. So this is our safe harbor timeline. Again, I'm going to go through some of this pretty quick, but I wanted to make sure before we come into session 2 that we're really all on the same foundation. In 2011, we passed a safe harbor law. So that law in 2011 said those under the age of 18 could no longer be charged criminally for engaging in quote unquote prostitution. So right, like we talked about earlier with language, there are still, the language is still used in statutes. And so there are times that I'll still reference it that way. So when we passed that law, we were the 5th state actually to have passed that law that protected minors from being treated criminally for those situations. We also implemented what's called the no wrong door model, which was basically a multidisciplinary, multifaceted approach to responding and identifying exploitation and trafficking. The goal is to really make sure that regardless of where an individual enters into the system, they'll be able to be identified and met as a victim survivor and offered services. So unlike other states that have passed the safe harbor law, we also put funding towards it. So we have 3 different kind of branches of funding legislatively. We have supportive services, we have housing grants, and then we have regional navigators. And again, that was so that we could really embody that no wrong door model. That went into full effect in 2014, and in 2016, we extended the age you could receive safe harbor funded services, and that is now up to the age of 25. So 24 and under can receive those state-funded services. I will say navigator services for myself, even if I can't use my funds to serve somebody, I do use my time to connect people so that we're not limiting assistance regardless of age. In 2017, we made a change to our mandated reporting law. Unlike most mandated reporting situations within the statute, trafficking is a mandated report, whether you suspect the perpetrator is a family member, caregiver, or person of authority. So it really expanded our child protection response to trafficking. In 2018, we made some statute changes to hotel motels. So it's part of licensure within 90 days of hire and annually that most staff are trained to identify and respond. We have submitted strategic plans to legislature to look at what safe harbor for all would look like. So a partial decriminalization model so that even those 18 and older could no longer be charged. Obviously that hasn't moved forward, but we have worked as a state to submit those plans and get the ball started on those conversations. 2021, we have some changes to our Family First title for funding. And this means that we have more options for housing for minors that need a trauma-informed specific approach to their care. And then we have some changes to mandated reporting and other situations in through 2024 and 2025. Again, it's mostly within the mandated reporting realm. But also our child protection response is going to change just a little bit as well. So we're working on, there's been some changes to mandated reporting, including extortion is now child abuse. And that plays a role, obviously, in our exploitation and trafficking. And then we're working on including labor trafficking into our mandated reporting response as well. So just really quickly, I wanted to go into, because as mandated reporters, you're going to want to know what's the difference in Minnesota between sexual exploitation and sex trafficking. So sexual exploitation is like this large umbrella, and we have a lot of things that fall under it, including sex trafficking. But sexual exploitation is the exchange of something of value or the promise of something of value for a sexual favor or act. So again, that thing of value does not need to be exchanged. It just needs to be promised. And that thing of value is really anything perceived of value. So food, clothing, a place to stay, drugs, it could be transportation. So I think as you dive into conversations with your patients that are using substances, you'll probably find that they have engaged in this sexual exploitation or commercial sexual exploitation on a regular basis. It becomes sex trafficking in Minnesota when we have a third party identified. So we have a trafficker, a buyer, and a victim. And that's when it becomes sex trafficking in Minnesota. Individuals engaged in commercial sexual exploitation, whether that's 2-party or 3-party, are still able to receive safe harbor services. Our response for mandated reporting for vulnerable adults and child protection, that's where we want to know that indicator between those two. But again, for referral for services, we want to encompass all these situations. So when you're trying to identify and respond to this within your roles, we really want to better understand the entire sex trafficking ecosystem, right? We have multiple parties involved. And just to keep in mind that even when we only have 2 parties involved, where we have that exploiter and the victim, we still have a crime and we still have victimization. So just to keep that in mind as we move through, I'm going to talk about traffickers as well so that we can embody all of those types of commercial sexual exploitation. So when we look at traffickers, it's important to understand the safety implications and who we're looking for. Again, so that as we're talking to people within our offices, we really take into consideration the splitting people up and talking to our patients privately, because we never know what the dynamic of that relationship is going to look like. But a trafficker's criminal history, so there were a few studies done. One was a 6-year analysis that I thought was really, really helpful. Out of Arizona. And the reason I think it's helpful is because it really showed us because traffickers are so hard to identify at times, it gave us some really good information about what to look for and what trends we're seeing within our traffickers. So what they found was that traffickers typically had a history of domestic assaults. So again, sometimes we're looking, and oftentimes because there's a relationship between a trafficker and a victim survivor, there is domestic violence involved. So we have a multifaceted situation of victimization. So we can be looking for things like signs of domestic violence as well. So history of domestic assault, prior use of weapons. Again, this is important to understand that similar to domestic violence, leaving those abusive relationships is very dangerous. And so for us to keep that in mind when we're safety planning with individuals or even offering resources when someone's leaving our office. Past trafficking charges, and then a lot of our traffickers have a history as juveniles in the system as well. Information about them, what we're finding, and this is very similar to what we're seeing in Minnesota for numbers as well, based on results from our funded task forces in the state, is that traffickers, we're no longer looking for this huge age differential. They're actually finding that over time, traffickers are getting younger and younger. And in this 6-year analysis, they found that average age of traffickers was 28 and a half years old. Many cases took up to a year to locate the trafficker. Again, not as important for you guys to take note of, but understanding that these cases are really drawn out. And so when we think about our victims that have come into contact with our systems, we do see a lot of them because these systems are so long, or these cases are so long, that it gets really disheartening. And we have a lot of people that end up falling back into substance use just based on the stress and the trauma of the fear of not knowing when their trafficker is going to get arrested. Main recruitment tactics, again, we're seeing that providing substances is significantly used in recruitment tactics. We also know, and we'll talk about it a little later, but I'll just reference it now as well, about 85% of people that are trafficked are also using substances while being trafficked. So even if it's not being used as a recruitment tactic, it's often used as a coping skill as well, or a coping mechanism as well. Sexual assault, physical assault, but increasingly we're seeing that basic necessities like housing and food and transportation are being used as recruitment tactics as well. So these are just numbers from Minnesota. Again, I wanted to just show that, again, the age that we're seeing traffickers the most in is that 18 to 35 pretty consistently. This is outdated now, but they haven't released a new one in the last few years. But we are seeing pretty similar numbers when we're having conversations with those task forces. We don't have stranger abduction. So when this was released, out of all of our funded task forces, we had 0 cases involving stranger abduction. We really do see that it is a relationship is formed, or with minors in particular, over 60% of those cases are still familial based. So taking into consideration, again, when you're having those conversations with caregivers as well, that if there's concerns of trafficking and you're working with a minor, there still is a pretty high percent chance that it's familial based. So then we look at who's supplying the demand. So human trafficking, which is labor and sex trafficking, is usually the second to third largest criminal enterprise in the world. So we know, just like drugs, which are usually the first, the highest criminal enterprise worldwide, that it happens everywhere. So is trafficking. So we wanted to know, why. So who supplies that demand? And that's typically in Minnesota. And there's a study, it's down here, but I'm happy to send it out if anybody would like. It's called Mapping the Demand. And it was done by the University of Minnesota and the Women's Foundation of Minnesota in 2017. It looked at who is supplying that demand. So what we found were our primary buyers in Minnesota were typically middle-aged married white men from across the entire state. People are often traveling between 30 and 60 miles to purchase, and they're typically purchasing during commute hours or over the lunch hour. So to work, from work, or over the lunch hour, or when our demand and purchasing times go up. That doesn't mean that people can't purchase during the evening and things like that, but what we're finding is usually chatting between buyers and victim survivors are going up in the evenings, and the purchasing is still happening more likely during those commute hours. They're really purchasing experiences of power and control. So a lot of the times the victim survivors that I come into contact with identify as participating in this by choice. It was a survival thing. I chose to do this, groomed into it, kind of you name it. And I think that's unfortunately the perception that our communities have, is that this is a service that someone's choosing to go do. What we're finding again is that what buyers are purchasing is really experiences of power and control, quote unquote, a porn star experience, risky sexual acts, things like that. So then looking at the Minnesota Student Survey, and I just want to kind of get a pulse. Are you guys familiar with the Minnesota Student Survey? If people could just put in the chat, yes or no, or do thumbs up, thumbs down. Okay. I'm seeing a decent number of no's. So I'm just sorry for those yeses. I'm just gonna quickly go into it. So the Minnesota Student Survey goes out every few years to participating school districts across the state. And really it is a comprehensive public health touch point with youth. In 2019, for the first time, we had a question that went out to 9th and 11th graders that was specifically about exploitation and trafficking. So we've had 2 Minnesota Student Survey sessions now, or surveys that have gone out now that have had this exploitation question added to it. So again, it's comprehensive. It talks about ACEs, it talks about food insecurity, it talks about other types of victimization, it talks about incarceration in the home, substance use. It really is this comprehensive health survey. And so with that, though, we finally got a touch point where we had self-disclosures coming from youth. And that's been so critical for us to have some hard data that goes along with what we were seeing in investigations and hearing from clients, but hadn't really had the research to show in numbers yet. This in 2019, our percentage for youth self-identifying exploitation was 1.4, so it went down 0.1% in 2022's. However, we also had a significant decrease in schools that were participating in this survey. So, we are seeing fairly consistent numbers in the state, taking into consideration the schools that opted out of participating. It is an opt-out, so this is always a baseline number, but it's an underestimate. So it was 5,000 youth in 2019, 4,600 youth here in 2022 that is underestimated have experienced exploitation and trafficking. Underestimated again for a number of reasons.
So Kate, just a quick question. Is there a difference between rural and metro?
So as you guys can see, do you see the map down at the bottom here? So we have all the different regions that are listed. The East Metro and West Metro had lower percentages than a lot of our outstate regions.
Oh, yeah, I didn't see that.
Oh, yeah, I'll go into some of that too, but please ask. And if you're wanting to know more about what your region of the state was seeing in correlation, between different forms of victimization or different health-related concerns, please let me know. And if you're not in my region, I'm happy to or one of my 2 regions now, I'm happy to connect you with your local navigator to learn a little bit more about the co-occurrence that youth are particularly seeing in your area. Because we have people from all over, I'm not going to go into East Central data or Northwest data. I'm just going to look at the state data. So that number is underestimated for a number of reasons. One is that parents can opt out. So when we think about over 60% of our mandated reports around exploitation and trafficking right now are still familial based, it makes sense, right, that family would pull students out rather than have them have this opportunity to do this health screening survey or social health screening survey. The other reason is youth, it's only given one day. So if you're truant or sick or, dropped out or whatever the situation, if you're not at school that day, you're not able to participate. So that's another reason. When we have youth that are truant, they're at higher risk of exploitation and trafficking. Youth that are on run are at higher risk of exploitation and trafficking as well. And if youth are currently in substance use treatment, they're also not being offered this survey, right? So again, for those reasons, it's also an underestimate. And then lastly, it's an underestimate because in a lot of our rural communities in particular, there's not a lot of diversity. We know that our minorities are victimized at a higher rate as well. And if you're the only Black student in 9th grade in your entire school, you're probably not going to feel like you have anonymity in doing this survey because it has you also list your demographics. So again, lots of reasons that this is an underestimate, but those are some of the ones that I just wanted to highlight today. So 1.3% said, yes, we've experienced, that's our general population, that is, I should say, metro areas, I'll just go through, were 1.2 and 1.1. My East Central area was 1.5. Our rural communities in northern Minnesota consistently have had the highest rate of self-disclosures. So when you think about the communities that you're serving, the communities with less access to resources, less access to shelters, drop-in centers, affordable housing, all of those things, we're going to see an increase risk of exploitation and trafficking because those vulnerabilities aren't able to be met as easily by the communities. So less access to resource, more opportunities to experience that grooming, right? That grooming for basic necessity and need. So those are the split up for areas. I will say that youth that have completed or been to treatment for substance use, the youth that have been to treatment, they're reporting 12% of those youth. So 12% of those youth compared to 1.3% of the general population. That's pretty significant. So again, keeping in mind that youth and adults that are using substances are experiencing at significantly higher rates. The other thing that we're seeing a lot is that, again, 1.3% for general population, boys and girls were only 0.1 or 0.2% different for cisgender boys and girls. So we often see this as a situation that's impacting our girls and women. However, again, based on these self-disclosures from youth, boys are being victimized at about equal rates, if not equal rates. And in some counties, they're experiencing victimization at significantly higher rates than cisgender girls. Consistently across the board, we are seeing that our LGBTQ plus youth and two-spirited youth are being victimized at the highest rate when we break it down based on gender, and our Native youth are being victimized at the highest rate based on race. So this is just my East Central data because I'm not a part of child protection, so I can't pull it for myself around the state. But I wanted to just give a snapshot of when we're looking at these reports and these mandated reports. And I saw a comment in there that someone was unsure that they did not know prior to this that this was a mandated report. So just keeping in mind when we're talking about minors, but also adults, to keep in mind that even if we're not referencing abuse within the home or familial abuse, and we're identifying exploitation and trafficking, their exploitation and trafficking victimization may have started as a child within the home as well. So it's just important to understand that we do have a significant number of cases regarding familial trafficking. So just for East Central, that's just that 11 county area. We had alleged offenders that were relatives, 57% statewide. I know alleged offenders that are relatives or caregivers is about 64%. So a little bit higher statewide than what I'm seeing in my East Central area. Unknown offenders, 39%. Again, this can be kind of dangerous or feel very dangerous for our victim survivors that we're coming into contact with, because we're investigating a crime and we have no idea who that offender is. And we do know that that can be a safety implication if that offender is to get wind that they're being investigated. So, and then non-caregiver, again, a lot of our unknown offenders are most likely non-caregivers, right? If we can't identify who that offender is, but a known offender that is a non-caregiver was 8 to 2%.
Kate, I have a quick question.
Yeah.
Are we seeing increases in percentages in counties or regions that have like increased risk of like registered sex offenders?
You know, I have not seen any correlated data between registered sex offenders and an increase of exploitation and trafficking. I could see easily where if there are higher rates of known offenders, we may see higher rates of online solicitation and grooming. But I can do some digging and follow up on that question. I'll see if I can get the information for that for our part 2 on the 10th.
That'd be awesome. It just kind of piqued my interest with the non-familial offenders percentages.
Yeah. I'm just making myself a note because if I don't, I'll forget, and that's my honesty.
Sorry, I interrupted. Thank
No,
you.
no, thank you. Please. I love the dialogue. I just want to make sure I get done on time so you guys are all done with your lunches. So pathways to recruitment. Again, I'm not going to spend a lot of time on this because we've talked about it a lot, but just knowing, again, we have a lot of familial trafficking that can take place where we have generational trauma to consider and how this has been embedded into family systems. A lot of times when we have familial trafficking, we do see that a family member does have a drug or sex addiction. Maybe parents are selling their kids for sex in order to meet a drug habit. So again, just understanding that the dynamic, especially when we look at substance abuse, is pretty significant. Then we have child sexual abuse material, or CSAM, where we have explicit images and videos that are used to extort for further victimization. And then we have our unhealthy relationships, where we have unhealthy abusive relationships, whether that's romantic, friendships, employment, you name it. And then we fall through kind of the process. And again, I just wanted to show, just so that you guys are aware, even in your personal lives, how much the internet's taking a toll on this issue. 40% of teens, and this comes from Thorne, said that it's normal for people their age to share nudes with each other. So when someone shares a nude or asks for a nude, it's not sending alarm bells off in kids' heads. They're not blocking these individuals. They're leaving opportunities open for further attempts at grooming and solicitation and exploitation. The bar graph on the bottom are cyber tips. And for those of you that don't know what a cyber tip is, it's when an explicit image or video is shared, child abuse material on a site or website, Facebook, Google, anything like that. It gets sent to the National Center for Missing and Exploited Children, who identifies where the IP address stems from and sends it to the appropriate clearinghouse for that state. In Minnesota, our clearinghouse is the BCA, or Bureau of Criminal Apprehension. And I haven't gotten the numbers, or I don't have the numbers for the last couple of years, but it has continued to go up pretty significantly. I think last year they were at almost 10,000 cyber tips on the year. But you can see how our attempts of exploitation and trafficking, as well as self-produced or shared child abuse material, has gone up pretty significantly over the years. So when we talk about exploitation and trafficking, we really can't ignore this internet component. And really quick, just so that we cover it, is this grooming component. We do see that traffickers and exploiters really use this Maslow's hierarchy of needs. It's crazy. There's books that have been published by traffickers on teaching people how to use Maslow's hierarchy of needs to groom and traffic other individuals. They're out. You can buy them at Amazon. But we have, basically, they're just identifying where someone's at on Maslow's hierarchy of needs to know where they have to target those grooming tendencies or behaviors. What's important for people that are trying to offer services or safety to victims of trafficking and exploitation is to note that this is used to groom. So we need to make sure that we're very careful in our service provision or our offering of resources, that we don't use those same techniques. I see it a lot where, well, you could get this, we could get you transportation, but you'd have to meet with the advocate to get it. We don't want to do that. We don't want to tie basic necessities to a service. If they need a basic necessity, we want to follow that harm reduction approach and offer it. And we can offer the services, but we don't want to mandate that they coincide or need to coincide. So keeping that in mind when we're offering these services, that we offer them very open-ended. So healthcare's role. So, and again, I'm going to go more in depth into a lot of this in part 2, in particular, based on some of the questions that you guys have. Again, any questions you have, I'm going to do my best to, with the scope of time, really embed that into the training so it's comprehensive and really applicable tools to bring back. But upwards of 88% of victim survivors access a healthcare provider while being trafficked. So you guys are an integral part to identifying and responding to exploitation and trafficking. People are experiencing harm that bring them in to see a healthcare provider due to domestic violence, STDs, pregnancy, other physical harm and abuse that stems or symptoms that stem from the abuse, like traumatic brain injuries. I have another slide that goes a little bit further into it. Sexual violence and malnutrition and substance use are just a few of those reasons why people are going to be coming in to see a healthcare provider. So these are some common vulnerabilities, and I added in additional vulnerabilities that are common that you guys can look for in the healthcare sector as well. So signs of physical abuse and malnourishment, untreated medical conditions or STDs, STIs that are continuously being treated. If someone's lacking sleep, a lot of the times we forget that sleep deprivation is a tool that's used very regularly by abusers, in particular when we're looking at this form of abuse, because of the high demand, staying up and chatting or seeing buyers at night and during the day. And there's not a lot of extra time for sleep. People might be using substances to stay awake as long as they need to stay awake. But again, it's also used as a tool for abusers to create like a false sense of reality for somebody that has such a lack of sleep. Mood swings, dissociation, anxious, fearful, hypervigilant is probably a better word to use rather than paranoia. Hypervigilant, obviously, there's reasons for that hypervigilance. So we want to really validate the reason for their fear and concern, rather than attribute it to paranoia. May provide really inaccurate information or changing information, maybe always changing address, location when they're coming in on a regular basis, things like that. Isolates themselves from individuals, frequent emergency room visits, loss of bowel control, reports of sexual abuse. A lot of the time, what tips the scales for people wanting services when it comes to exploitation and trafficking is maybe a majority of their buyers, the dynamic of those sexual encounters didn't trigger what they identified as of sexual abuse, right? And so when a buyer is more violent, they may attribute it to sexual abuse and come in for an exam, but not report the trafficking component, right? It almost like differentiates in victim survivors' minds is it's a survival tool that sometimes they experience abuse from, rather than the whole situation being abusive. Self-harm, and again, substance use. Some of the other vulnerabilities that we see that you can look for that aren't necessarily related to the medical field, low self-esteem, well, it is, but low self-esteem, mental health, history in the system. So a history as a runaway, history as a foster care individual or someone placed within group homes, risky online behavior, and again, as minorities, taking that into consideration that again, our minorities are victimized consistently at the highest rate, in particular, our Native population. And I have it here, but HEAL, which is a great resource for medical providers when it comes to trafficking and exploitation. They have a lot of different resources. Again, I'm happy to send anything out if people are interested in learning a little bit more. But 85% of victims were using substances during their abuse, and that comes from that HEAL research that they've done. And I was lucky enough to be a part of Centricare developed a protocol in responding to exploitation and trafficking, and we got an algorithm added into the Epic system for them. And so we're really still rolling that out, and the trainings are going out, and we're just starting to see those numbers come in. And we used a lot of suggestions from HEAL for the development of that protocol as well. So if you're looking at trying to develop protocol within your own healthcare system, please let me know. If I can't be a resource, I'm happy to send resources that we use to develop the one with CentraCare. So key things to look for as healthcare providers. Someone that has unclear answers to injury. Again, a lot of this is tools that you're already using. It's just kind of opening the scope of what the victimization could look like, right? Because this is going to come and it's going to look like victimization in a lot of ways. Unexplained bruises, scars, burn marks, tattoos. And honestly, tattoos are so common now, but I always just talk about dialogue. So there's usually, maybe it seems like a very obvious tattoo. I just ask people to tell me about them. And if someone's really uncomfortable talking about a certain tattoo or a certain injury, I'd want to know a little bit more about that, or I just want to kind of catalog that in the back of my brain as a concern. Someone that's completely unaccompanied. I'm seeing more and more unaccompanied minors or foreign nationals, people without status that are coming in unaccompanied, minors and adults with healthcare concerns. Someone seeking medical care for untreated injuries or illness, or very late seeking healthcare. Sorry, I should say late to seeking healthcare for those injuries or illness. Multiple devices on them at all times, and again, just devices that connect to the internet, or feeling like they're constantly needing to be on their device. I feel like I'm a broken record because I've been saying this for years in every single training, but there's a big difference between somebody that wants to be on their phone, and I think this is something that more and more as adults we get frustrated with youth and young people that are always on their phone. There's a big difference between just wanting to be on it because it's a habit, and like seeing signs of anxiety when they're not able to answer their phone or check their phone. So kind of keep those things in mind. Lives elsewhere and is seeing you as a healthcare professional as someone that's traveling, or maybe consistently seeing you as a healthcare provider, but lives elsewhere or identifies living elsewhere. Again, malnourished, sleep deprived, or haven't had food. So if you're having concerns of victimization, adding in a question and you're screening with them about, so when was the last time you got, 6 hours of sleep or 8 hours of sleep, or when was the last time you had a full meal? And again, you can preface with, I just want to make sure that we can connect you to resources if those are needs that you have. It doesn't always have to be based on connecting to resources due to concerns of victimization. We can offer resources just based on those basic needs. Triggered responses to exams, in particularly one that we forget about a lot is oral exams. There can be a lot of oral trauma for individuals. So again, paying attention to how their body's responding to some of those exams and some of those touches, especially when they're not necessarily a forensic exam for abuse. Obviously, we're going to expect triggers there, but are people hesitant to being touched and things like that in regards to normal exams? So best practices, once identified, speak to patients privately. I always say create an excuse per protocol. This is what we have to do, because a lot of times abusers, even if it's not trafficking, are going to want to be a part of the conversation. Even during COVID, I was in doing some OB with some OB patients, and their significant other would mandate that they keep their phone on and be on their phone on speaker so that they could hear the conversation. So just taking into consideration that even if you're speaking with them privately, there might be somebody listening in on the phone too. So just kind of including that into your general practices. Create a safe environment for patient, allowing them to sit where they want in the room. I think you guys already do a really good job of this in general when I go into medical establishments, there's usually multiple areas that people can sit, but any opportunity to offer choice is going to make the situation seem a lot safer. Offer different ways to ask questions, so not asking questions specifically that revolve around the victimization, but questions around the concerns you have of health, other things that they're needing for basic needs, asking if they know anybody that has experienced exploitation and trafficking, because just knowing somebody puts them at higher risk of experiencing it, that we don't need to dive into their own situation as much to address them as someone that is in need of services. Again, asking what resources they might need, not just asking about what advocacy services they might need. I was working with, and I'm sorry, I'm going to multitask a little bit because I want to make sure my computer doesn't die. But I was talking with a law enforcement individual, and they had this woman who was in the jail, and I was talking to him after he had met with her, and he had just said, "Oh yeah, she's really not interested in any resources." Sorry, I should have done this beforehand, and I thought I had. And I said, "Oh well, how did you ask them?" And they said, "Well, I just asked if they wanted advocacy." And I said, "Oh geez." You know, most people in trafficking and exploitation, they don't identify as a victim, so they don't want advocacy. So I was like, well, why don't you just go see if somebody can come offer them resources like housing, food, transportation, things like that. And the person was so excited to have somebody come talk about that. And so it's kind of sometimes shifting the way we're offering the resources so where you don't have as many barriers. Connect to Safe Harbor advocacy. Again, not always listed as advocacy, but we have some pretty specific services and education around this. Be aware of your body language. Sometimes we still show signs of shock when we hear things, and that can come off as disbelief. Asking generalized questions like I had talked about earlier to establish risk. Offer harm reduction approaches. Preconceived perceived judgment that they might feel from you, especially if they are using substances and experiencing victimization. A lot of those individuals feel like that goes hand in hand. And then be aware that you may cause triggered reactions. So understanding that their trauma is going to come off, and it's not always going to be convenient how it does. We do have time. I'm hoping that the sound comes off all right. And I am seeing some questions in here. And if I don't have time to get to them today, I'll make sure I add them to our part 2. But I want to just show lifestory.org. It's an awesome resource. It's a ton of video education that are done by survivors of exploitation and trafficking. I will just note, it's about 5 minutes. It does focus on women and girls. Please know that these are things to consider for any of your patients that you come into contact with, regardless of gender identity. So I am hoping that it works. If it doesn't, I will send it to Katie and she can send it out and people can take a look at it in their own time. So maybe I'm just going to watch to see if somebody could put in the chat if you can hear it or not once I hit play.
I had found out that there are these things called escort services.
Can anyone hear it?
And I thought that I was like moving up,
Perfect.
a step. And it's the same. I mean, it's the same. You're just not getting into somebody's car. You're walking into somebody's house, or you're walking into a hotel room with a stranger. I mean, they still hurt you.
Everything was fine and dandy until the first time I said no.
The guy woke up, realized I was Black. That's what he wanted the night before, but he woke up, realized I was Black, and all hell broke loose in the room.
Una de las veces que recuerdo, el hombre me apretó tanto la boca que me rompió los dientes.
He broke my wrist. I got my hair cut off. Sliced my face. I've had guns put to my head.
Thrown out of cars, beat with a bat, had guns to my head.
And I remember sitting in the hospital, my chest was so heavy and I thought I was having a heart attack and I couldn't breathe.
I was terrified that this man who had just tried to kill me was going to come back and finish the job.
I was definitely afraid of being caught and found out. And if someone had said, I can help you on that day, especially on that day, I would have taken it.
I have this weird relationship with hospitals. Like, I'll go in for surgery because I like that they take care of you, you know? And that's what I appreciated. I will say that the nurses I remember in the emergency room showed kindness and compassion, but nobody asked me anything.
People who work on the front lines, like health professionals, can be such an important time, especially in a medical field. That might be the only time that woman is away from her trafficker.
I think that's definitely a great opportunity for someone to be kind of a first line identifier. There was a lot of training that went to medical people, social workers in hospitals to identify, hey, this person might be victim of some type of child abuse or domestic violence. I don't really see much of that on the trafficking side.
When I had my daughter, walked 2 blocks in my socks to get a cab by myself and went to the hospital and so scared. And I remember they asked, would there anybody be coming? And he didn't show up. And then he didn't show up. And I was supposed to be checked out of the hospital like 11. He didn't show up till 5. And I'm just waiting there. No money. I think that would have been odd.
I had over 18 emergency room visits. I was a child. I was out there. I was walking on the streets. You could tell I looked young. I should have been in school. To them, I was a prostitute. They treated me like I was dirty and that I deserved to have this abuse happen to me.
One time I went to the doctor and I went to urgent care. I told him that I was a prostitute and I was scared of what I might have. And he was like, well, you obviously have an STD. And just gave me some medicine, told me to go home. It turns out that I didn't have an STD. I just had like a cyst that bursted.
I had just been almost murdered. Nobody came to talk to me. Nobody.
Just
I
skipping ahead.
remember the doctor saying, can I talk to you for a minute? And I was like, yeah. And he asked me, was I under a lot of stress? He asked me, are you going to be okay? I said, yeah, I'll be fine. I think that I'm overworked. And he said, are you sure? I couldn't tell him out of embarrassment. Like, I felt like I was a strong woman. I am a strong woman. He never guided me to any other intervention, but just his words and him knowing was important to me.
So I skipped ahead for the sake of time a little bit, but I think really important to hear from victim survivors that, again, people are often coming into the medical field as victims after a traumatic incident. And sometimes you guys are in the best area of what we call stages of change model. And again, I can share more about that because we don't have time to go into it today, but at the best point in time to offer services to and to intercept the dynamic of that relationship for them. And just like in every profession, they had some really good experiences where it really impacted them and they remember it now. And then they had some not so good experiences. And we see so many patients, so many people every single day, just keeping in mind that like this can be such a meaningful time to ask those questions. And sometimes it's getting out of your comfort zone a little bit to highlight that these are my concerns. I did a survey to youth that are in receiving safe harbor services, so trafficking services in Minnesota. And I sent out the survey statewide. And one of the really important things that stuck to me, because we did this while we were developing a countywide protocol, and it was that these individuals had been referred to services and nobody that referred them to services in, I think, out of all the people that participated. It wasn't a ton of people that participated, but out of, I think, the 18 people that participated, 16 of those, the people that referred them to services didn't even talk to them about the concerns they had about exploitation and trafficking. So it's just a good reminder to get out of our comfort zone a little bit to offer those. I'm going to cover this more next time, just because we're running out of time. I always talk a little bit more. So I'm going to cover this last slide in our next training, just so that we end at a good time for everybody. So again, we're going to focus more on substance use and trafficking and dive into areas of interest that would correlate best with the systems that you're working in next time. This is my contact information. I'm going to stop sharing my screen for just a second, because I'm going to share a link to that form that I had talked about so that you guys can put in some of the topics that you want to learn more about. I'm going to take into consideration, obviously, the questions that were asked too that we didn't get a chance to address, or that I maybe didn't get a chance to address.
Thank you so much for that talk, Kate. That was excellent as always. I do have one quick question. What would you say is the most common platform currently being used for grooming?
Everybody always wants to know that. And it changes everywhere. Kids and young adults use different apps, are popular in different communities, in different school districts within different communities. So instead of being aware of one place, we just really want people to be aware of how to use platforms in a healthy way. Again, if many of you guys might be parents or grandparents or aunts and uncles, talking to kids about safe places to be interacting online and how to do it safely is the best thing you can do, rather than to be aware of a certain app, because that's changing all the time. Keeping in mind, though, that sometimes we want to divert kids without parental oversight to programs or apps or games that are meant for kids. Perpetrators go to those apps looking for kids because they're meant for kids. So allowing access to the internet without that oversight and guidance, regardless of what apps you're allowing them to use, can be just as dangerous. Thank you.
Wow. Yeah. I don't know, Erin, what do you think? We're a little over. Do we hit a couple of these questions if people want to hang around, or?
Jenny put one in the chat. She said, why do you think the rate of disclosed abuse is higher in rural rather than metro?
Yeah, again, I think that it really, and I know I touched on this a little bit, but it really comes down to, we think about all of the things, the basic necessities that are used to groom and exploit. When we have these rural communities that don't have access to safe, healthy options to meet those needs, we're going to have more situations where the grooming is going to be fruitful for exploiters. So I think a lot of it comes down to the access to resources.
Sure.
Somebody asked when the follow-up will be. It's in 2 weeks. Actually, Dr. Resnikoff is next week, and then Kate's going to come back the week after. And then I think, maybe Katie, if we could just save those couple of questions that we had earlier that we didn't get to, then we'll maybe start with those on the next.
Yeah. Of course. And if you guys are able, I know Katie's the whiz here, or I don't know if she's on, but if anyone's able to send me those, unless people want to add that into that Microsoft form that I sent the link to, I'm happy again to address any of those questions that come up.
Yeah, perfect. Well, Kate, again, like Erin said, fabulous as usual. So really appreciate your time.
Yeah, thanks for having me back.
Thank you.
All right, thanks everybody for coming. We'll see you next week with our friend Charlie Resnikoff, and then 2 weeks, Kate will be back to finish the show. So thanks again, everybody, for coming.